Okay, let's talk about the innervation of the scapular muscles. And as we do, we're going to answer a few questions like, what nerves provide innervation to the muscles that move the scapula? And what are the clinical presentations of injuries to these nerves? So let's get started with the dorsal scapular nerve. And you can see here we have an image of a right brachial plexus. And just a reminder, the brachial plexus is formed of ventral rami from C5, C6, C7, C8, and T1. And then these ventral rami all meet and merge and they form this plexus of nerves. So the nerve branch we're going to talk about here is the dorsal scapular nerve, and that is coming directly off of the C5 ventral ramus. Now let's take a look at a new image so we can see what the brachial plexus actually looks like in the neck. So you can see here we've got a mandible here, so this is an anterior view, and right here is where we're seeing the brachial plexus. So it's wedged between these two different muscles. So we'll label that brachial plexus here, and then these muscles, this one is called the anterior scalene. This one right here, posterior to the brachial plexus, is the middle scalene. The reason I bring this up with the dorsal scapular nerve is that here on the brachial plexus, this branch is the suprascapular nerve, which on our diagram is right here. So it's more distal than the dorsal scapular nerve. So the dorsal scapular nerve, to get back to where it's going, actually has to pierce the middle scalene muscle. That's important to know because the dorsal scapular nerve can become entrapped or compressed as it pierces the middle scalene. So with that in mind, let's talk about the clinical presentation of the dorsal scapular nerve. So some of the issues that we might see with the dorsal scapular nerve injury are, one, the scapula is probably going to be unstable. We're also probably going to see diminished ability to retract as well as to elevate the scapula. There's also likely to be pain or muscle tightness in the superior medial back, but we're not going to see any loss of cutaneous sensation. Now, based on that clinical presentation, let's figure out what muscles are innervated by the dorsal scapular nerve. So we're looking for muscles that would typically retract and or elevate the scapula. When I look here, we've got this posterior view. I can see the spine of the scapula. Looking at this view for muscles that might retract the scapula, it looks like this muscle here, if it was to shorten, it would retract the scapula or pull it closer to midline. Same with this smaller muscle up above. If that was to shorten, it would pull the scapula closer to midline. And then looking for a muscle that would elevate the scapula, it looks like this muscle here coming off the superior angle. If it was to shorten, it would elevate or raise the scapula. So putting those in our table, the first one we've got is the rhomboid major. That is this larger rhomboid shaped muscle right here. That muscle does scapular retraction and it's innervated by the dorsal scapular nerve. The next one on our list, rhomboid minor, so smaller and just above major, that also does scapula retraction, innervated by the dorsal scapular nerve. And then finally, we need a muscle that elevates. So what would you name a muscle that elevates the scapula? We're going to name it the levator scapulae. It elevates the scapula and is also innervated by the dorsal scapular nerve. And that is it for the dorsal scapular nerve. One question you might have had with this clinical presentation is, what about the trapezius muscle? So I have the same question, and that is what we're going to talk about next. Now that we've switched slides, you can see that the clinical presentation for the trapezius is very similar to what we would see with the dorsal scapular nerve. So the trapezius right here gets its name based on its shape. The upper fibers of the trapezius elevate the scapula. The middle fibers are going to retract the scapula, and then the lower fibers can depress the scapula. And all together, these will also do upward rotation of the scapula. So we'll add that to our table here with those different actions. The innervation of trapezius actually isn't from the brachial plexus. It's from a cranial nerve called the spinal accessory nerve, and that's cranial nerve number 11. So you might be asking, how can we differentiate a spinal accessory nerve injury from a dorsal scapular nerve injury? Well, the spinal accessory nerve actually innervates a second muscle in addition to trapezius, and that is the sternocleidomastoid muscle. And we're kind of seeing a part of it here and here, and that muscle is responsible for doing contralateral head rotation. So for example, the right sternocleidomastoid is going to turn your head to the left. So an injury to the spinal accessory nerve might present very similar to a dorsal scapular nerve injury, but with the SCM, if that is involved, the patient might also have issues turning their head if the spinal accessory nerve is injured. And that's it for the trapezius. So let's move on to the long thoracic nerve. So again, we've got our image of the brachial plexus. The long thoracic nerve here comes from C5, C6, and C7, and then that's going to continue down along the superficial thorax. So that's kind of where it gets its name, the long thoracic nerve. An injury to the long thoracic nerve will present as a winged scapula, and that's what we're seeing in this image here, where this patient's right scapula, instead of staying right against the thoracic cage, it is coming off that wall, and we can see that really prominently here. And then we also will see the presentation with diminished ability to protract the scapula, but then we're not going to see any cutaneous sensation loss. The long thoracic nerve is only responsible for innervating one muscle, and we've got it pictured here. It's the serratus anterior muscle. It gets its name because it looks very serrated, and we have some that are more posterior. This is the most anterior serrated muscle that we have. So its action is to protract the scapula, bring it forward along the rib cage, and it is innervated by the long thoracic nerve. And I want to switch images and show one other image of the long thoracic nerve. So here's more of an anterior view. We can see kind of the shoulder, the right upper limb, and then this muscle here, we're kind of seeing those finger-like projections. That's the serratus anterior. You can see this long thoracic nerve here is found superficial. So it's actually pretty unique. Most muscles are innervated on their deep surface, but the long thoracic nerve is actually on the superficial surface of serratus anterior. So that can make it a little bit more likely to be injured because of its superficial location. And that is it for the long thoracic nerve, so let's do a quick review. We learned that the dorsal scapular nerve innervates the rhomboid major, rhomboid minor, and the levator scapulae muscles, and that's going to present with weak scapular retraction and elevation if that nerve is injured. And then we talked about the trapezius will have a similar presentation if that muscle isn't functioning. It's innervated by the spinal accessory nerve, so if that nerve is injured, it's going to have a similar presentation, but also with the involvement of the sternocleidomastoid, a patient would have diminished ability to turn their head. And then finally, the long thoracic nerve innervates serratus anterior. And we can actually see it in this image. Kind of right here, we get a little piece of serratus anterior. And an injury there is going to result in a winged scapula and diminished ability to protract the scapula. And that is it for the innervation of these scapular muscles.